this takes a little bit of time to help people understand how to use it. And then one day the light bulb goes off and people are like, oh, this is great. So in order to get there, you have to help your client understand what all the variable pieces are and how to integrate it. You also have to choose the right employer. Okay, not every employer is a great fit for this at this time. Okay, so we've been very fortunate. Our clients always give me some version of, look, we'll spend the money if we have to, but we spend a lot of time and a lot of money and a lot of internal resources, and everybody hates it. Right? I'm sure you've all heard that, right? So, even if they know that, it doesn't mean that they know how to solve the problem. Okay, because this is a complex problem and different employers will have different needs. You know, manufacturing will have different needs from biomed, different needs from high tech, from banking, from different kinds of industries and different kinds of employee groups. So it's important to tailor the solution to that particular employer. So when we talk to clients, we always tell them that their buying journey should look something like this. Choose somebody that understands that the system is broken and knows how to fix it, because we know that not everybody knows how to fix this, right? And make sure that you're philosophically aligned. If your employer group is saying, we really like United Healthcare, we don't want to change anything, we just want to pay less, not the right client for this. And that's okay. They may change their mind in a couple of years. Forget big. It's slow, it's status quo, it doesn't help anybody, it just kind of moves along, keeps increasing in costs, right? So you have to have good conversations about how to migrate away from that. And that may not be a one-shot deal. That may be something that takes a couple of years, and that's okay too, right? A good solid 3 to 5 year strategy will help with the culture of your employer groups or your clients, and will also help the employer move people along this journey, because we are changing how they engage in the healthcare system, right? And that is very personal to people. And finally, you need clients who you can have a good conversation with, or a good fight. You know, I had a knockdown drag out with one of my clients the other day, and they're not doing what I want them to do in one area, but they are in another. But we have great discussions about it, and it's really, really important that you have the ability to have those discussions. And the other thing is, you need to talk about what happens if something fails. Not every strategy is great for every client, and you may try something and it doesn't work. It has to be okay. And I've found that if you address that up front, then you're in a much better place when you get to that point. So, stakes are high. Insurance costs are too high, increasing at an ever-expanding multiple, and people are not being treated well, right? People are not getting good outcomes, and they're getting angry. They know they're not getting outcomes, they're spending too much money, and they're mad. So we have to do something. And on more than one occasion, I have been called the East Coast liberal hippie chick, but even I know that governmental intervention is not the way to solve this problem. So let's get to it. All right, we're going to talk about choosing the right third-party administrator, administrative items to address, and things that we wish we knew, or maybe things that I wish I knew. They might be different from Dr. Rogers. So, most important, every stakeholder in the group needs to be on the phone in the room when the decisions are made. You need the employer, you need the TPA, you yourself need to be in the room, and you have to have good, broad conversations about how things are handled. Different DPC practices work in different ways. You're all your own business owners, right? So one DPC practice may work this way, and another one may work another way, and another one may work a third way over here. And where that kind of rubs with a TPA is they need a little bit of consistency. Okay, so most importantly, they need to know who pays what and how much. So some DPC practices are an all-inclusive model, right? They tend to have a little higher monthly cost, but they'll cover basic lab and imaging in their fee. They may charge an office visit, they may not, like a $10 copay or something for coming into the office. There are other practices that have maybe a little bit lower fee, but pass along their pricing for lab and imaging. Okay, so you need to have a good conversation about how those things are going to be both accounted for and paid for. Okay, in my experience, the TPA that we use, we send the data over once a month and they add it to the accumulator. We have yet to get to somebody's deductible with costs that come from the DPC practice, by the way. Now, there's a little lab work here, there might be an x-ray here. It's almost nothing, but we do need to make sure it gets to the accumulator, and that's the insurance part, okay? Now, most DPC docs, you have direct primary practices because you don't want to deal with insurance, right? If you want to engage with employer groups, you're going to need to engage with the insurance system just a little bit, okay? We've made it very easy. We literally have set up a process where the DPC practice records all the expenses for the month, lab work, x-ray, whatever they collected from the employer's patients. They send that data to the TPA at the end of the month. The TPA updates the data, and that's it. The key here is, though, that they need the CPT code. Now, a lot of you don't use the CPT codes or don't keep track of it because you don't need it for your own practice. If you're going to engage in the employer market, you're going to need to do that. That doesn't mean that you have to argue about getting paid. It doesn't mean that you have to offer a discount. It doesn't mean any of those things. It just means that you need to tie your service to a CPT code. Okay, now if you're using an EMR, that might already be built into your system. Okay, and technical requirements. Really, it can be as simple as a Google Doc, sent securely, by the way, because you've got PHI in there, personal health information. So it can be that simple. But again, conversations up front about how that happens. Plan design and administrative items. Design, be in the room when the plan is designed. Talk about how you can bring the most value. And again, you're all a little bit different. So how you bring value may be different for different employers, or you may have your model, but make sure that both the employer and the TPA understand what the model is, and the advisor, by the way. That's important too. Make sure you've got the data transfer set up. If you can do that ahead of time, if you've got an employer that's getting a little bit ahead, so we're making decisions 60 or 90 or 120 days out, you'll have more time to manage the administrative details. And it's amazing. Something always goes wrong, but when it goes wrong 60 days ahead of time, it's way less stressful than when it goes wrong 30 days after implementation. Okay, so work on those things as well. The TPA does need claims for processing, right? So if you have a practice where the member is paying for lab work or x-ray, and really they don't pay you much more for much more than that, you need to make sure that that is set up properly and that the communication is going. It's really very simple. It's just a matter of getting it set up right. And then I would encourage all of you to track your savings, right? So Dr. R is going to talk about some great case studies that he has where he has saved literally over $1 million in 1 year just in one particular area. It's really important that you communicate that to your employer clients if you're a DPC doc. And I know for plan vendors in here, you're already doing that. It's really important that people know that your service is working. It's also really important that you're tracking not just the financial outcome, but the clinical outcome as well. And you'll see that in the overall claims. And if you are a DPC doc, ask to see the claims, right? Usually that's okay. My clients are typically okay with that because we're trying to create something holistic and take care of people and not just manage claims. So you shouldn't get too much pushback on that. All right, things we wish we knew, and there are a couple. Leverage every on-site opportunity that you can. Anytime that you can get in front of an employee and talk about holistic care and health and well-being, not let's go have a group walk. I don't find that to be particularly effective or particularly engaging for people, but how to be healthy. Make sure you're sleeping. Make sure you're eating properly. Make sure that you do get some motion, right? That's a big part of physical health, and DPC docs are a big part of that. Have that conversation. We found that year-round conversation with that done by Dr. R, done by internal safety people, done by me, keeps people engaged and moving. And you may not see great results right away, but you will over time. And you do want this to be a long-term relationship. Make sure that the plan is paying commodity prices for commodity care wherever possible. I know that people, general public, thinks that high-cost care is the best care. We know that's not true. We know that the dirtiest secret in healthcare is that the highest quality care is almost always in the bottom quartile of cost. So it doesn't necessarily need to be the cheapest, but it does need to be a fair price. Okay, you can help facilitate that. Relationships with outpatient facilities. Make sure that if you end up with somebody with appendicitis in your office, that you have a resource for them to go to. Okay, that's a weird one. I know it may never happen again, but we literally had a person who walked in the door at 4 o'clock with appendicitis, and we could not get that person to a freestanding facility that day. We had to send them to the emergency room. That just, to me, was a waste, right? So make sure that you have access to a cash pay surgical facility and good relationships with surgeons who can help you out. The surgeon for us was not a problem, the facility was. Okay, make sure that you can reach out to Dr. C at Green Imaging and you can take care of imaging needs at a fair price and quickly. You know, make sure you've got a relationship with a lab. Most of you do. Make sure you have a relationship with specialty labs so you can get favorable pricing with specialty labs, because there will be some specialty work that comes your way. That is all the mechanics we have. I'm going to turn it over to Dr. R.
Thank you, Allison. Thank you. So I'm Roger Moczygemba. They just usually call me Dr. Roger. I am so, first of all, how much time do we have?
25.
Okay. So the way we kind of structured this is to both present, and then afterwards we wanted to leave a little time for a discussion, so questions. So I am so excited to be here today, not today to give a talk, but that this day has come, because 4 years ago when I started my direct primary care clinic, I knew that I could provide wonderful clinical outcomes for people and employers, clinical outcomes for them and financial outcomes. But I struggled to talk to employers about how to do that. And today, DPC and what we're doing has evolved to the point that we can do it now. With the good help of folks like Allison, we're walking the walk. We can do it now. We can go to employers and show them how to incorporate this wonderful value of direct primary care. So that's what I'm so excited about today. So one of the things that we can do as DPC docs is to become familiar and get acquainted with the employers, and we can do that by doing biometric screening for them, like Allison mentioned, doing on-site stuff for them. We can go out and do flu shots for them. We can do COVID testing for them, and whatever you can think of as a doc. Just do something to kind of get to know the employer. And I'm saying this because we've noticed this pattern. We have this relationship with an employer. They've got their plan, and things are hard to change, especially with big companies. But as they get to know us and warm up to us, then they start listening a little more. And then another thing that's happening with us is a beta test. I think it was already mentioned here. We're doing a beta test with a company where they'll like, okay, well, we like what you showed us. Let's do a beta test. So this one company put their C-suite, they just bought the memberships for us. And we took care of them like we usually do as a DPC, and they loved it. And we had a follow-up with them after a quarter, and they're like, okay, well, that was good. Let's expand the beta test. So they put some of their production people on the test. And we know that's going to go well. So probably by this fall, we will have an offering in their open enrollment. So the point is, get to know employers as a doctor or clinic and start to take these baby steps with them. So another thing that we can do as docs is we can leverage our existing contract with our labs and imaging connections. I'm going to show you an example of that in a minute. So what we do is we pass through this cost for lab and imaging to them. There are ways to do that other than just in my local area through companies like Green Imaging that has a large footprint, and of course LabCorp and Quest, they're all over. So this is an example of the power of doing something like that, because we as doctors or a clinic, we have our own access to lab cost. So this is what it cost us right here. This is what the traditional cost would be for an employer going through their insurance plan. So this came from an annual report with an employer. We're showing them our value. So we see the number of tests that we did, and then what it would have cost traditionally, what it would have cost traditionally as a total, and what it actually cost them. So we talked yesterday in our chapter leader meeting about telling our story. This is a big story to tell in my mind, and it's this kind of thing that I think will get the attention of employers. So you can do that as DPC docs. Now, the other thing that Allison touched on is this plan design. So as we work together with an employer and go into their workforce and do our thing as DPC docs, we'll get a certain amount of engagement initially, but as the employer plan design drives utilization to the clinic, this beautiful thing happens. The idea is to help them eliminate any fees for office visits or labs or imaging. Just try to eliminate any barriers to access. That is so key. Try to eliminate barriers to access. Then the employer can promote these other things down here, like texting for appointments and becoming their new medical home and after hours access. So the employer can promote all that. And I love this graph because it shows what happens naturally when a DPC does his thing, okay? The first year engagement started here, and the second year, look what happened here to the use of direct care, and look what happened to the use of the traditional system. So year after year, look what happens. Isn't that a beautiful thing? Okay. Now, that leads me to this slide, because this is up here in the corner to show what's happening as the DPC gets their arms around chronic disease management, engaging with the employers with these diseases, using or limiting advanced care when we can do that. One of the ways that we do that in our clinic is with a company called Rubicon MD. So we use them to extend our reach and our care as primary care doctors to help the patient not have to see a specialist if they don't need to. Then these are just some other statistics that we showed the employer in our annual report. This one here was pretty significant, where it talks about avoided care, and we try to let the employer know that as long as we're contracted with them, we can take care of their work injuries as well. So we track how many of these we take care of on a pre-claim basis for the employer, and then we show them how much it would have cost if that work injury would have gone into the traditional fee-for-service system with their work comp carrier. So that can be really huge. We also keep track of how many visits we think avoided a trip to the ER or urgent care, and that can be really huge too. The way I like to explain it to employers is they're going from this capitated system, which they already paid for, into a system that thrives and grows on looking for ways that they can add charges to the super bill and run up the cost. Okay, so the more engagement they have, the more this circle spins out these great outcomes here. So in this example, they paid us this, and this is what they saved. So this is another part of the story that we need to tell. And so now this slide reminds me that there's so much that we can do as direct primary care docs. We can take care of folks on the phone. We can take care of folks virtually. I could just talk on and on about the great virtual care clinical outcomes that we had, from keeping people out of the ER to just, all kinds of great stuff. We find that, with medications, we help them find economical prescriptions. This reminds me of the specialists that I already talked about. We help limit the referrals to specialists. And then a lot of times employers will ask, well, how many clinics do you have? Well, I have one, or I have two, but there's this affiliate program now that we have. We use, this is so easy to use within the HINT system. We can just add an affiliate anywhere, and that's a beautiful thing. So is this scalable? Yes. Employers need to know that if they're in this city and your clinic's in that city, but they also have employees scattered out across the state or in other states, no worries. We have affiliates, and we're in the process of doing that. So to end this, I just want to make sure that everybody knows, as we are putting these plans together, that the doc, the employer, and the TPA, if we keep the employee and their family at the center of what we're trying to do, it's going to be a win-win situation. So if we keep them in mind, it'll all work out, and it'll be sustainable. So now we're at this point for questions. Yes?
How do you utilize health share plans, or do you? And how does that fit into this? I guess maybe with smaller employers?
Sure, yeah. So we, in my clinic, I have a guy called a doctor program liaison, and he's the one that is actually kind of closes the deals with small companies and large companies. And when those questions come up, he is very familiar with the health share opportunities and what they are and how they work. So if he's talking to a company that is looking for a solution for care above and beyond what a DPC can offer, he'll talk about a health share plan with them.
So piggybacking on that, I do a lot with the health shares to a great degree of success in South Carolina. I have issues when I get into large self-funded employers. So Allison, or please comment. So listing off, number one, you get into a larger self-funded group, the monthly fee just gets heavy for those. And you see a CFO looking at the potential savings, but then the additional fixed costs ranging between $60 and $100 a month. Secondly, as you pointed out, with the implementation with the major medical, and I get everything you're saying. But at the end of the day, we're all slave to insurance on the larger groups. The reinsurance always wants a prior authorization for whatever, and the DPC, forget about coding, that's an issue. And then thirdly, I forgot, I'll come back to this. So, you understand?
So that is part, for me, that prior authorization is part of the conversation between the TPA and the employer and the advisor and the stop-loss carrier.
Yep.
And we've successfully ameliorated it. We have not eliminated the pre-cert, but we have certainly simplified the process. And that is just the reality. And for any employer with more than 50 lives, the health sharing won't work because of the penalties. So
We'll talk about that after. But,
Fair enough.
I mean, so even simplifying, and I think the great thing about DPCs is everybody's independent and free thinking. The bad thing is everybody's
independent and free thinking, yes.
So you can say, hey, the PA is one page, and yet someone will do it and someone won't.
Well, but that's their choice. That's their choice as a DPC provider, and that's the choice of the TPA and the employer. So if everybody's having a conversation and they've come to agreement, it's all right. You can find a way to work it out. But I just go back to that. Everybody has to be in the room having the conversation. I don't speak for Dr. Roger, and I don't speak for the TPA, and I don't speak to the employer. I make them talk to each other. And it can be hard sometimes to get everybody in the room. But when you do that, you get a better outcome. And you may go a little slower in your plan, like we generally work on 3 to 5 year plans. It may slow our plan down, but everybody trusts everybody else. And, you know, that is the currency today, right? Trust is the currency.
So I just want to mention too, for the other docs in here, that I think it's really important that we be fairly assertive in this process. I mean, traditionally, we're like benefits, I don't know about that, but you need to be there because you, Mr. Doctor, are the one that has control of those savings that I put up there.
And
Yes. No, that's it.
I want to add one more thing. You know, this pre-cert process, right? Everybody's like, oh, it's pre-cert. Really, they're checking for medical necessity. They don't care what it costs. They don't care, you know, the pre-cert vendor, right? Because every plan has one. They don't care what it costs. They don't care where you go. They don't care what it costs. They don't care where you go. They're just checking for medical necessity, right? So if you're ordering an MRI for an inappropriate thing, they're going to say no. How many of you are ordering MRIs for inappropriate things? Anybody? Okay. So it's not that big of.
I get it, it's not, and that's the whole thing, like, it's not that big of a deal, but everybody makes it a big deal, just nobody wants to do the damn thing.
I get that too. But that is the price of doing business with larger employers.
And that's because of the stop loss that needs to be increased? Is that where that comes from?
Typically the stop loss will require it. The stop loss will require a couple of things in terms of identifying and managing.
Is there ever a world where maybe the stop loss lessens that requirement as they do business with you and they do business with the DPC?
Yeah, but then it's a liability issue if something ever were to go.
So I'm going to speak a little insurance ease. I hope that's okay. So a typical self-funded employer with more than 100 employees on the plan would have a specific deductible of $40,000 or $50,000. So what happens under that $40,000 or $50,000, actually what happens under half of that $40,000 or $50,000, the stop loss vendor won't necessarily care about unless a huge claim comes out of it. So it really is just dotting I's and crossing T's. And some stop loss carriers are a little more forward thinking than others. And, you know, there are several advisors in this room. I know who to go to. Brett knows who to go to. The other advisors I don't know, so I can't speak for you. But we generally know where we're going to get favorable treatment.
Yeah, it seems like if I was in the doc's shoes and I didn't want the pre-cert, I think finding not just the employer, right, at your first slide of going to do the flu clinics, but finding the Allison, so, you know, who has the relationship with the stop loss, who's not going to make you do a pre-cert, seems like the first filter I would do before going to an employer.
That's why it takes those 3 pillars, right? Yeah, that's a beautiful thing. Mm-hmm.
Hunter, you mentioned that you were doing workers' comp. So when you do workers' comp, you're stuck in that system. That's a state system, correct?
Well,
Like in the state of Texas, you do workers' compensation. And I guess it depends if they're a subscriber or not.
well,
If
not,
they're a subscriber, because I know there's some companies that maybe are self-funded for their medical needs, but for workers' comp, they're a subscriber. And under Texas law, we have to follow the workers' comp rules. Are you guys doing that, or what are you doing?
So what we do is we tell these employers that we'll take care of these injured workers, and we'll let them file what's called a $0 claim, just to let their work comp carrier know that there's been an injury, but it's already paid for. Okay, so under our direct contract relationship, we're treating those injured workers. And so most of the time, they're bumps, strains, overexertion, and things like that. And we can take care of that all day long and get them back to work. But if it doesn't, like if they're going to need a surgery or it's going to get expensive, then we'll let the employer know, hey, look, this is getting a little complicated, and then the employer can decide when they want to turn that into a claim, but it's not going to be, we're not trying to do anything under the table here against the work comp carrier, because we've filed that $0 claim. So the carrier knows, okay, there's been an injury, but it's $0, so I don't need to pay anything on it. I hope that makes sense.
Does that improve or lessen the cost for the employer as to their...
Absolutely, because when they file a work comp claim, they're going to pay for that, but it's just going to be magnified down the road and stretched out over the next 3 years, right? So I tell these employers, if you're in a financial position to pay for these claims up front directly, then do it. And a lot of them get it, and they do.
No, I understand completely. I
Okay.
run on-site clinics, and
Okay.
we take care of first aid stuff.
Right.
First aid is 50% of what you're going to see. You can help an employer like that.
Right.
But the other part, you might be an employer, the company would never let you do what you're doing with backs and knees, because those end up being high dollars. You almost always report those, right? There's different things, but that's out of your hands, and you're not even, you're going to have to give that to another person, correct?
Mm-hmm. Right.
Great presentation, both of you, by the way. The reporting system that you use, what do you do? Is all of that able to be pulled from your EMR?
That's a great question, and that's a great question. So we are pulling all that from our EMR. It's Allison. It's not easy. We're spending a lot of time on it. We're getting better and better at it.
Okay.
Yeah. So.
And what infographics, or where do you get your infographics? It looks really good.
Thank you. Where's Andre? Stand up. These two guys right here.
Good job, guys.
Yeah. So they're my, Shankar Pansale is my co-founder of the San Antonio chapter of the FMMA. And I'm fortunate to have him. I'm fortunate to have Allison, just some great people in my life to help this good thing move forward. Yeah.
I'm intrigued by the affiliate arrangement, and through Hint, I've had some DPC docs in my area talk about the ability to work together. And if you think of employers, 100 plus, they're going to have employees not just in scattered geography, but maybe within the same market, and want to offer choices to their employees.
Mm-hmm.
How would you recommend that from being just a total free-for-all? I mean, is there a case where you, as the lead DPC with that relationship, would kind of corral some of that?
Yes, and actually that's how it's working for us. We have an employer in San Antonio, I've got a couple hundred people, and we're doing this beta test with them, but they have another company, same size, in Oklahoma. So I kind of handpicked a DPC clinic over there, and I said, hey, this is what's going on. Would you be an affiliate with me? I've got this employer in your backyard, and this is the goal, And they're like, sure. So it was so easy to just put that together in the back office with Hint, and the employer pays us, the DPC, and in the back office, I've got a staff that just click, and then the other affiliate is paid.
See, to me, that seems like that addresses some of the difficulty with the reporting and with some of the other DPC docs unwilling to do pre-search or pre-auth. If you have a clinician like yourself that is willing to translate and transfer some of that credibility to those other clinicians, I think that's where we get a long ways down the road.
Right.
Rather
And,
than an insurance person
right.
or a TPA talking about it.
Right, and I think another thing that it does for us is it enhances that employer-clinic relationship because they know that I'm accountable even for what's going on with the affiliate. So I think that's what they need also. The TPA just needs one place to pay, ideally, right? So,
Does that affiliate, do you have to work out agreements as to what your member rates are, I mean, there's so many unique features of every DPC. It seems like you'd have to level the playing field if you're going to engage the same business at two different locations.
yes, yeah, that's something that you would need to work out.
I want to add something about, I've heard a lot of concern about pre-authorization. You know that that's fungible, right? So you may not need a pre-auth for an MRI if it comes from the DPC doc, right?
Yeah.
I wouldn't create a plan that would allow a surgery without a pre-cert, but that's just me. But you can be fungible in a lot of those things and make that work for every constituent.
So I work in a kind of weird space. We do direct primary care and we're also a TPA, so we've merged those two things together in a sense. And what you're saying, so basically using our direct primary care for our labs or imaging, we don't require any sort of pre-cert or auth or anything like that. But also with ours, what we do, when we're asking for a pre-cert, we're also requiring them on that pre-cert saying, we agree to this cash rate or this Medicare rate, or, so what we're doing is also making it drop in cost for the employer groups that are.
And that's fine, but
Yeah.
it's stop loss.
Ours is, it's not just for the stop loss too.
Right, so it's not, I mean, I agree, you can really do anything, you can waive it all day long, you get to find a willing stop loss partner to underwrite that risk.
We have willing stop loss. We have willing stop loss. That's not a,
Yeah.
that has yet to be a problem for us. It should not be a problem for you. If it is, let's have a conversation, because it should not be a problem.
The other question I have is with regard to just like reporting, running an EMR that's able to capture all these CPTs and ICDs that you might need. What happens if you can't get those CPTs really easily, we don't have a system for that? What does that look like on the TPA side, and how much does that really impact?
It looks like somebody from the claims department calls me and says, "What is this?" And then I have to sort that out, is what that looks like.
So for most routine DPC care, it's probably not a big deal, even especially in those plans where if I order an MRI, it's just like it's just paid for, we don't worry about it. But if there are bigger expenses or bigger.
So nothing that happens in your office should really go to the TPA unless a member paid for it. Okay, so if your model is that you charge cost plus 10% or 20% for lab imaging, whatever it is, that is what needs to go to the DPC. Nothing else that you're doing needs to go. That is a function of payment and helping a member meet their deductible. That's all that is. And that is separate from pre-auth. And pre-auth is pretty fungible. And again, just requires good conversations between all the parties.
Thank you.
I got a question. As an employer, if you don't have a DPC clinic or doctor in your area closer to where all of your employees reside, like I think the closest one that I think we can find is like 45 minutes away. Is there anything an employer can do to work with maybe finding one?
Yes. So I would encourage you, one, to check the Hint network, because sometimes DPC docs are not readily visible on Google.
So I would comment, are you done?
Nope.
Okay, so I helped start 2 nationwide telemedicine companies, and so virtual care is really, really a powerful tool these days, and we can do a lot through virtual care. So that DPC doc that's 45 minutes away, you might just want to visit with him and see what what he's like, what he can offer.
Your population that's under 30, and I'm a way bit older than under 30, and I still fall into this group, we really just want to talk to the doc. We don't want to go there.
You're wrong.
Yeah.
Musculoskeletal management is a big deal, right? That happens to be my space in my life. Where does physical therapy and physical medicine fit?
I defer to you.
Okay, so that's a great question because there's a lot of cost involved with that, right? So,
I think there's more cost not using this. That's my.
so I personally like to be aggressive with physical therapy early, and I have an arrangement with a DPT, Doctor of Physical Therapy, and some other therapy clinics. And so I can actually just call this guy on the phone. I say, hey, this is what I think's going on. Can you see this guy? And he'll see him. He'll see that patient. And then we have an arrangement that he will bill me. And then I'll pass that cost on to the employer. It's the cash price for this specialist.
What's the price that you're negotiating?
It goes by whatever service he performed. But
Roughly $80, $60?
I think he did an eval for me recently, and it was like under 200, like 150 or under 200.
That's pretty pricey.
Well, that's for a whole eval, the initial evaluation. Okay. Okay.
Eval is not a big deal.
Okay. Okay. Well, maybe I'll revisit that with him. Thank you.
So really, there's nothing, nobody else knows any other.
Our provider, so I work with a larger employer, self-funded insurance, so we use KPP with their price for physical therapy in the Dallas Metroplex, Tempton, Premier.
Do you use third parties administrator, you negotiate the contract?
And like I just did one for 77 a session,
That's one reason.
and it's here in the Dallas Metroplex.
In the back.
We have a full PT network in Colorado that we use. It's mainly private PTs. Some of them are larger, are part of a bigger group, but we have PTs actually in our clinics. Some of our clinics, just like with behavioral health.
And mine's a private one that's a mile from our factory, so that way they can do their physical therapy, but then go back to work.
Sure. I'm a chief my own whatever. I'm a physical medicine rehab physician, right? And the last 15 years or so, I've been doing what's called musculoskeletal ultrasound. So you know how expensive
Fantastic. MSK ultrasound's fantastic.
ultrasound's great. Thank you. Anyway, but you know how expensive MRIs are, right? So if you can find somebody that does musculoskeletal ultrasound, you can diagnose every and any rotator cuff tear.
Save them, or
It's-
it's even better than
Yeah, we're talking about $100, $150 compared to whatever imaging company charges you 400 or whatever it is, a great deal. So I just find that there's a lot of underutilization in MSK, and that's what, my partner and I have been trying to figure out how to get the word out.
In the back.
Yeah, you mentioned submitting information back to the self-funded employer to collect towards their deductible and their accumulators. Is that their monthly cost? Is that their, what exactly is going back towards the deductible?
No, so what I was talking about is accumulators refer to what the employee pays because good Lord, I can't even talk anymore. Every health plan will have a deductible or a max out of pocket that the employee is responsible for. So you have to be able to capture any of those expenses.
So anything that the
employee
pays out of pocket.
Correct.
Will be counted towards their out of pocket.
Correct.
accumulators. Cool.
Correct.
Very cool.
Probably need to wrap it up.
We do.
Okay. Thank you.
Thank you, everyone.
Thank